We are about to pour $50 million into this incredibly futuristic, fast-tracked medical breakthrough for mental health. But the underlying science actually suggests this massive leap forward is going to completely fail.
Right. Unless, of course, we pair it with the human practice that is literally thousands of years old.
Exactly. So welcome to today's deep dive. Our mission today, as always for you listening, is to really just cut through the noise and explore the absolute frontier of mental health treatments.
Yeah, and we've got a fascinating topic today.
We really do. We are focusing heavily on a recent Psychology Today article by Dr. Alan J. Steinberg. This was updated on April 24th, 2026, and it's titled, What's Still Missing for the Executive Order on Psychedelics?
And honestly, the timing of this piece just couldn't be better. I mean, we are looking at a very modern, rapidly moving policy change here.
Oh, totally.
And Dr. Steinberg argues that for this policy to actually translate into long-term healing for patients, the entire clinical framework basically needs a radical redesign.
Right. So let's get right into the news hook that kind of sparked all of this. On April 18th, 2026, Donald Trump signed an executive order, and it's designed to accelerate the development of psychedelic drugs as medical treatments.
Which is a huge deal.
It is a massive deal. Now, really quick, a heads up for you listening. We are looking at this executive order purely through the lens of medicine, neuroscience, and regulatory science.
Right, exactly.
We're just unpacking the source text to see how this impacts mental health treatment. So we are setting all the partisan politics completely aside. We're not taking sides here, just looking at the facts.
Yeah, and I mean, the science and the regulatory frameworks are definitely complex enough on their own without adding politics into the mix.
So true.
If we look strictly at the specifics of the order itself, it represents a highly aggressive push to change how these substances are handled at a federal level.
Okay, so what does it actually do, practically speaking?
Well, it directs the Food and Drug Administration to fast-track compounds that already hold a breakthrough therapy designation. It also mandates interagency data sharing, creates a direct pathway for rapid rescheduling upon potential FDA approval.
Wow.
Yeah. And crucially, it commits $50 million in federal funding to clinical trials.
I mean, $50 million. That is a massive, immediate influx of capital for this specific area of research. So for the listener, why should you care? Like, why is this happening right now?
It really comes down to desperation, honestly.
Right. The urgency is all about the sheer persistence of conditions like, treatment-resistant depression, severe PTSD, and addiction.
Yeah, and we are seeing these crises particularly compound among veterans right now.
Exactly. The existing pharmacological models have basically just hit a wall in terms of effectiveness. So if this executive order functions as intended, we could see psychedelic-assisted psychotherapy, or PP as it's called, move into broad clinical use within just a couple of years.
Which means the stakes are just astronomical here. I mean, we are talking about millions of people who have spent decades cycling through conventional psychiatric models without any real relief.
Just trying pill after pill.
Exactly. But this rapid acceleration forces two really massive questions. The first is whether PIP is actually safe and effective enough for FDA approval across broader populations.
Right, which is the whole focus of the current Phase 3 trials.
Yes. But the second question, and this is what Dr. Steinberg argues is dangerously underdeveloped in this current clinical rush, is how should this therapy actually be practiced to produce outcomes that don't just, fade away over time?
Right. And that is the central mystery of our deep dive today. Is the current clinical model for psychedelics actually missing a crucial piece of the puzzle to make the healing permanent?
It's the million-dollar question, or I guess the $50 million question.
Right. To understand what might be missing from this new executive action, we first have to kind of look under the hood. How do these substances actually change the brain in the first place?
Well, it requires a pretty profound shift in how we view pharmacology altogether.
How so?
Well, with conventional medications, say SSRIs or targeted anti-anxiety meds, the goal is really to modulate neurotransmitter levels in the background. The patient isn't really supposed to feel the drug working in real time.
Right. You just take it and go about your day.
Exactly.
Yeah.
But with psychedelics, the prevailing scientific consensus is that the drug works precisely by inducing specific, highly intense subjective experiences.
So the subjective experience isn't just a side effect, right? Like the experience is the actual mechanism of change.
Yes, that's exactly it. Research characterizes these as mystical type experiences.
Okay, mystical type.
Yeah, we're talking about a temporary, complete dissolution of self-boundaries,
Mm-hmm.
a profound sense of unity with the environment, and heavily altered perceptions of time and space.
Wow.
And studies from institutions like Johns Hopkins have repeatedly shown that the intensity of this subjective mystical experience strongly correlates with and actually predicts the actual therapeutic outcome for the patient.
Okay, let's unpack this. Because, talking about mystical experiences as a medical mechanism can sound a bit, well, esoteric.
Oh, for sure. It sounds like magic.
Right. But there is hard, measurable biology happening alongside that subjective feeling.
What's fascinating here is the neuroscience, actually backing this up. At the neural level, psychedelics dramatically reduce activity in something called the default mode network, or the DMN.
A DMN.
Yeah, and the DMN is essentially the neurological seat of your autobiographical self. It's the network responsible for self-referential thinking.
So it's basically the voice in my head.
Pretty much. It's the part of you that projects into the future to worry, dwells on the past, to ruminate, and just maintains your rigid sense of identity.
Right, okay.
So when the DMN is taken offline, psychedelics act as biological catalysts. They temporarily but massively increase neuroplasticity. The brain suddenly has this uninhibited capacity to form new connections and basically reorganize its deeply entrenched pathways.
Okay, let me put an analogy on this just to make sure we're on the same page. Think of the default mode network like a really popular sledding hill.
Okay, I like that.
After decades of sliding down the exact same path, which in this case represents years of chronic depression or trauma, the grooves in the snow become so incredibly deep that you just can't steer out of them.
You're just stuck in the track.
Exactly. No matter how hard you pull the sled, you just keep careening down the exact same negative pathway. So taking a high-dose psychedelic is kind of like a massive, fresh blizzard.
Right.
It completely fills in all those deep ruts, leaving a smooth, untouched hill where you finally have the freedom to chart a totally new, healthier path.
That's a perfect way to look at it. The brain becomes highly impressionable, and the structural rigidity of those pathological thought loops is, well, temporarily suspended.
Temporarily, right.
Exactly. And this leads us directly to the core problem Dr. Steinberg highlights in the source material. What happens when the blizzard is over?
Right. And that brings us to the biggest limitation of current psychedelic-assisted psychotherapy, the so-called state-to-trait problem.
Yes. Psychedelics are remarkably reliable at inducing powerful psychological states. And a state is a temporary shift in perception, emotion, and identity.
Like the few hours you're actually under the influence.
Right. You administer the substance, and for like 6 to 8 hours, the patient exists in a state of profound openness and unity. But for any lasting therapeutic benefit, those temporary states must translate into permanent traits.
Okay, and traits are?
Traits are the enduring everyday architectures of the brain. It's your default behaviors, how you process stress, and how you regulate your emotions on, a random Tuesday morning months after the session.
But the article points out that this state-to-trait conversion is absolutely not guaranteed by the drug alone. In fact, it often fails.
It is arguably the glaring flaw in the current clinical model. I mean, a patient might have an earth-shattering experience that feels completely transformative in the clinical setting. They gain profound insight into their trauma, yet 6 months later, they find their underlying behavioral patterns, like the depression, the addictive cravings, the anxiety ascends, have just crept right back into their daily lives.
Wow.
Current PAP protocols are excellent at inducing the beneficial state, but they systematically fail to stabilize that state into a lasting trait.
Wait, I actually have to push back on this because it feels completely counterintuitive.
How so?
Well, if someone has a profound mystical experience, like if they literally feel absolute unity with the universe, their fear of death completely evaporates, and they emotionally process decades of childhood trauma in a single afternoon, isn't that memory alone powerful enough to permanently change their behavior?
You would think so.
Right. I mean, how could a human being possibly revert to their old self after gaining that level of universal insight?
It's a great question, but the clinical data absolutely refutes the idea that memory alone can sustain behavioral change.
Really?
Yeah. A profound memory is, well, it's a psychological artifact. But conditions like severe PTSD or deep-seated addiction are biological architectures.
Ah.
The brain is an ultimate efficiency machine. It operates on energy conservation. So those deep neural grooves you mentioned on the sledding hill,
Yeah.
they are heavily insulated by myelin sheaths built up over decades, and their entire purpose is to make those negative thought loops fast and effortless.
Oh, wow. So they're physically wired to be the easiest path.
Exactly. The neuroplastic window created by the psychedelic is incredibly brief. And once it closes, the brain will naturally seek the path of least resistance, which is always its oldest, most entrenched biological habit.
So insight is essentially useless against biological gravity.
Well, insight is a prerequisite for change, definitely, but it is not the mechanism of sustained change.
Got it.
The current clinical protocols usually involve just 1 to 3 high-dose psychedelic sessions. There's some therapy beforehand to prepare the patient, and a few therapy sessions afterward to discuss the insights.
But just talking about it doesn't fix the biology.
Right. Discussing an insight does not physically rewire the brain's baseline. Without rigorous ongoing structural practice, the brain simply defaults back to its highly efficient pathological patterns.
So the blizzard stops, the neuroplastic window closes, and the sled just starts carting out the exact same heavy ruts it has known for 20 years.
Unfortunately, yes.
So if that is the biological reality, how do we keep the neuroplastic window propped open? Here's where it gets really interesting, folks. Because Dr. Steinberg's article suggests the solution is not some new synthetic booster chemical. It is actually an ancient practice.
Right.
Meditation.
Yeah, the article draws a really compelling parallel between the underlying mechanisms of psychedelics and meditation. Far from being unrelated practices, they actually operate on a shared neurological continuum.
Which is fascinating because, behaviorally, they seem like complete opposites. A psychedelic session is often this intense, chaotic, emotionally explosive inward journey, right?
Very much so.
While meditation is generally viewed as sitting perfectly still, anchoring your attention, and cultivating absolute quiet.
The external behavior is totally different, yeah. But neurologically, they're doing complementary work.
How so?
Well, if we connect this to the bigger picture, functional MRI scans show that meditation, specifically sustained practices, also significantly reduces activity in the default mode network.
Oh, really?
Yes, advanced meditators show a baseline DMN that is far less active than the average person. The practice also produces experiences of self-transcendence and openness.
Just like the psychedelics.
Exactly. The critical difference lies in the delivery system and the duration. Psychedelics force the DMN offline massively, all at once, for just a few hours.
Like flipping a breaker switch.
Right. But meditation trains the brain's physiological capacity to access and sustain those modes of awareness incrementally over time.
But the article specifies that meditation actually changes the physical structure of the brain over time, right? Like, it isn't just about suppressing thoughts or chilling out.
Oh no, it alters the physical hardware. Sustained meditation practices actually thicken the prefrontal cortex, which is the area responsible for executive function and emotional regulation.
Wow.
Simultaneously, decreases the reactivity of the amygdala, which is the brain's fear center. So while the psychedelic provides rapid, forceful access to a state of openness, meditation develops the actual neurological muscle required to maintain and integrate that openness into everyday life.
Okay, so if we know that meditation is the missing piece, like the daily practice required to convert these temporary states into permanent biological traits, how does this actually apply to the $50 million in federal funding?
That's the key issue.
Like, when exactly in the clinical process should this tool be deployed to actually maximize its effectiveness?
Well, timing is everything in pharmacology, and it is especially true here. Emerging research points to a specific, critical window of opportunity immediately following a psychedelic session.
The afterglow, right.
Yes, often referred to in the literature as the afterglow. For several days and sometimes even weeks after the acute effects of the drug wear off, the brain remains in a state of heightened neuroplasticity.
So it stays impressionable for a bit.
Exactly. Levels of brain-derived neurotrophic factor, or BDNF, are elevated. The brain is literally growing new synapses and is exceptionally receptive to new behavioral patterns.
Oh, wow.
This afterglow period is precisely when a structured meditation practice must be aggressively introduced.
So what does this all mean for the current clinical trial designs? Because from what Dr. Steinberg outlines, the current integration practices being tested for FDA approval are just kind of loose, intermittent talk therapy sessions.
Which is really concerning.
Right. Testing psychedelics in isolation without a rigorous, structured integration practice to capitalize on that afterglow. It seems like putting a cast on a broken leg but refusing to prescribe physical therapy after it comes off.
That's a great analogy, and it highlights a critical vulnerability in the current research paradigm. We are fast-tracking trials that risk giving patients profound insight without the structural scaffolding necessary for lasting change.
Which means they'll just relapse.
Exactly. The patients gain clarity during the session, but they lack a daily, repeatable method to prevent their neural pathways from migrating back to their baseline states.
This raises an important question, though, regarding how we actually spend that $50 million. Like, how do we fix the trial design before these funds are deployed?
Well, Dr. Steinberg offers a very specific, actionable recommendation for these fast-track trials.
Okay, what is it?
He argues that future clinical trials triggered by this executive order must include what he calls a contemplative-informed integration arm.
Contemplative informed integration.
Right. If researchers are just testing PAPAP against a placebo, or PPAC with standard talk therapy, they are missing the most vital variable for long-term efficacy. We need trials that formally incorporate standardized daily meditation protocols into the weeks and months following the psychedelic session.
Well, what kind of protocols are we actually talking about here? Because, meditation is a huge umbrella term. Are we talking about visualizing a beach or something more clinical?
The trials need highly structured, empirically validated frameworks.
Mm.
One primary example he mentions is mindfulness-based cognitive therapy, or MBCT.
MBCT.
Yeah.
Oh.
MBCT trains patients in interoceptive awareness, which is basically the ability to observe negative thought patterns or addictive cravings arising in the body without actually identifying with them.
Oh, I see.
Another approach is automatic self-transcending practices, like transcendental meditation, which allows the mind to basically settle into a state of restful alertness. By introducing these practices during the neuroplastic afterglow, patients actually learn to self-regulate.
And the goal of adding this specific integration arm to the trials is to measure something very specific.
Right. Yes. The primary metric must be relapse rates. We really need to determine if a standardized daily meditation practice significantly reduces the rate at which patients revert to severe depression or addictive behaviors.
That makes total sense.
Furthermore, we need to see if this practice decreases the clinical need for patients to return for repeated high-dose psychedelic sessions months later. Does the meditation make the initial healing durable?
Right. Because if the FDA trials don't test for that, the data on long-term effectiveness will be deeply compromised. I mean, we might hit a point 5 years from now where the medical community deems psychedelic therapy a failure because the relapse rates are too high.
Well, the reality is we simply failed to give patients the daily tools required to maintain the initial healing.
Wow, exactly.
Without incorporating these comparative integration models, researchers are essentially flying blind regarding long-term care. And, this specific debate pushes the entire medical field to confront a much broader philosophical issue about mental health care as a whole.
Really? Like what?
Well, historically, psychiatric research has been obsessively, almost exclusively, focused on symptom reduction. The clinical questionnaires mostly just ask things like, are you less sad? Are you having fewer panic attacks? Have your cravings decreased?
Right, the baseline for success is really just, did the immediate pain stop?
Exactly. But both psychedelic research and the study of contemplative practices suggest that we have the capacity to aim much higher. Dr. Steinberg points out that we shouldn't just be measuring symptom reduction, we should be evaluating increased well-being.
Like actual flourishing.
Yes, a renewed sense of meaning and purpose in life, and an increase in pro-social behavior, things like empathy, altruism, and connection with others.
That is a huge paradigm shift.
It is. If treatment is defined narrowly as just stopping acute symptoms, maybe a few isolated psychedelic sessions are sufficient. But if the goal of this $50 million federal push is sustained psychological health and genuine human flourishing, a one-time pharmacological intervention is never going to be enough.
Well, it has to be followed by a daily process that actively supports continued neurological growth.
Precisely.
And meditation is perfectly suited for that exact role. I mean, as the source material notes, it is highly accessible, it's infinitely scalable across a population, and most importantly, it does not depend on repeated, expensive pharmacological interventions.
Which is huge for the healthcare system.
Totally. A patient doesn't need to visit a specialized clinic or get a new prescription just to sit in their living room and engage in a practice that keeps their default mode network in check.
Exactly. It creates a complete, durable, and highly empowering model of care. The psychedelic compound induces the temporary transformative state that breaks the rigid neural pathways and enables psychological reorganization.
Right.
And then the contemplative practice provides the practical, daily mechanism for stabilizing and extending those changes over the rest of the patient's life.
It's a perfect pairing.
It really is. It aligns perfectly with modern neurobiology, with the subjective reports of the patients themselves, and frankly, with the clinical reality that trauma and depression are chronic conditions requiring ongoing active maintenance.
Man, this has been an incredible deep dive today. We started with a sudden, massive shift in federal policy. An executive order committing $50 million to fast-track psychedelic medicine and potentially reshape the FDA's entire approach to mental health.
A lot to take in.
For sure. And from there, we dove into the neuroscience, looking at how taking the default mode network offline temporarily smooths out the deep, rigid ruts of our mental habits.
The blizzard on the sledding hill.
Exactly. And finally, we arrived at the really profound realization that a cutting-edge 21st century pharmacological breakthrough might actually rely entirely on a 1,000-year-old contemplative practice to work long-term.
It is such a powerful synthesis. I mean, the executive order reflects a new willingness to explore treatments that deeply engage with subjective human experience, moving beyond mere chemical modulation.
Right.
But as Dr. Steinberg so clearly points out, the missing piece of this puzzle is the recognition that the mechanism of healing has to extend far beyond the clinical session itself. Including meditation and study designs doesn't complicate the science. It completes the biological picture.
It gives people a way to keep the door open, to basically keep the sled from falling back into the same old ruts.
Absolutely.
Which leaves us with a final thought I really want you, the listener, to mull over today. We have spent a lot of time talking about the default mode network, that rigid, autobiographical voice in our heads that is constantly defining our boundaries, defending our ego, and maintaining our sense of self.
The storyteller.
Right. So, if both psychedelics and meditation heal our deepest traumas by physically turning that exact network off, it forces us to ask a rather uncomfortable question. Is the rigid, everyday self that we spend our entire lives trying to protect, promote, and improve actually the very disease that is causing our psychological suffering in the first place?
Wow, that's heavy.
Think about the sledding hill. Maybe the goal isn't to build a stronger sled. Maybe the goal is to realize you don't always have to ride it.